Good morning students, I am Dr. Abhijit, working as Assistant Professor in the Department of Oral and Maxillofacial Surgery in Vinayaga Mission's Shankaracharya Dental College. Today we are going to study about suturing techniques. So what is suturing? So suturing is basically required in the field of oral and maxillofacial surgery. So it is a routine procedure which is being done in our college or in oral and maxillofacial surgical cases at the end of the procedure. So it is basically required for closure of the wound or operated site. So today's contents involve the introduction, suturing techniques, components of knots, types of knots and suture removal, when, where, how it has to be done, and references. Coming to the introduction. So the primary objective of suturing is to position and secure the surgical flaps in order to promote optimal healing in primary or first intention that provides the support for tissue margin until they heal without dead space and reduce the postoperative pain. Inadequate suturing may result in a flap skipping, or it can cause exposed bone or necrosis, which can lead to pain and delayed wound healing, which we routinely see in patients. That is why the suturing is really important in patients. So coming to the suturing techniques, we have simple interrupted suture technique, we have continuous non-interlocking suture techniques and continuous locking suture, figure of 8 suture, vertical mattress suture, horizontal mattress suture and sling suture. So coming to the basic simple suture, how we do? So basic interrupted suture or simple interrupted suture is basically we will take the needle or with the needle holder and then we insert the needle in the buccal flap first, and always from buccal flap to lingual flap we insert the needle, and once both needle has penetrated both buccal and lingual flap we will make the knot. Now we have to study how to make the knot. So to make the knot there is a guidelines or set of rules that has to be followed while making a knot. So during making a knot, first we will take the clockwise rotation and then anti-clockwise rotation and then again clockwise rotation, and we give a 3 knots for this suture to be more stable for the patient. So always there is principles of suturing, we have to be very careful with the needle. Always the needle should be penetrating perpendicular to the tissue and then it has to come out of the buccal flap. We will take out the needle from the buccal flap and then we have to insert it into the lingual flap in the alveolar segment. Once we take out that, then we will tie the interrupted suture. Next variety of suture comes is the figure of 8 suture, which is most commonly used for extraction socket closure as well as for adaptation of the gingival papilla around the tooth. So this is more oftenly used especially in the case of mandibular first molar or maxillary first molar, where the buccal and lingual flap has been raised very widely due to the surgical approach. So once most commonly which is used for the extraction socket closure as well as for the adaptation of papilla. So the needle is first inserted into the outer surface of the buccal flap and then the lingual flap. Then we have to cross over. So the needle should be again inserted onto the same fashion but at a horizontal distance on the opposite end, and then the both ends are tied together to finish the figure of 8 knot. Next comes the simple continuous suture, where the simple interrupted suture is placed and then the needle is reinserted in a continuous fashion such that the suture passes perpendicular to the incision line below and obliquely above. So advantage of such a suture is it's a rapid technique and it distributes the tension uniformly, and more watertight closure can be achieved in such a continuous closure, and only 2 knots are required in the start as well as the end. So the disadvantage of the suture is if you cut at one point of the suture, there is a chance of suture getting removed on the other end. So coming to the continuous locking suture, continuous locking is very similar to the normal continuous suture, but here only thing what will be done is the intermediate locking will be done. So that is, the locking is provided by withdrawing the suture through its own loop. So we will make the loop once we take through the lingual segment, lingual flap, and then we will pass the needle through the loop so that there will be locking at the one point which happens on the lingual flap. So that is called as continuous locking sutures. So what is the advantage of continuous locking sutures? So it will avoid multiple knots, distributes tension uniformly, watertight closure is possible and prevents excessive tightening of the suture. So that will lead to the proper closure of the wound and also the better healing for the patient. So coming to the disadvantages, it prevents the adjustment of the tension over the suture line because we are locking the suture between the loop. So more or less adjustment is not possible in between that. So that is the disadvantage of this interlocking technique, and it can be used anywhere. It can be used extraorally, it can be used intraorally in alveolar segments, and also in it can be routinely used one of the suturing technique for especially maxillary segment after the maxillofacial surgical procedure. So this is one of the picture which depicts the continuous locking suture, where we are taking the suturing needle from the buccal flap and the lingual flap, then passing the needle through the loop what we have created, and then we will do the same procedure in a continuous fashion to achieve the continuous locking suture. So next comes the vertical mattress suture. So what is vertical mattress suture? The vertical mattress suture, here the suture needle passes at two levels. So basically we will take the suture needle one deep to provide the support, and then adduction of the tissue wound surface at the depth, and then one bite superficial to draw the edges together and evert them. So basically it is used to close the deep wounds. So here in this picture, as mentioned in this slide, a needle is taken deep the tissue, first deep bite, and then from the buccal flap, and then on the lingual flap again in the deep aspect, and then the second knot will start from the lingual side, and we have to take more superficially compared to the first bite, so that first two bites is always deep and second two bites will be always superficial, so that the wound closes in the deep as well as in the superficial aspect. That is the advantage of the vertical mattress suturing. So coming to what all advantages: for better adaptation and maximum tissue approximation, and to get eversion of the wounds slightly, and when healing is expected to be delayed for any reason, it is better to give an added advantage with the support of the vertical mattress suture, and it also used to control the soft tissue hemorrhage. So basically this vertical mattress runs parallel to the blood supply of the edge of the flap, and therefore it doesn't interfere with the healing. So that is the main advantage of the vertical mattress suture, which is very routinely used in the field of oral and maxillofacial surgery, especially for major cases. It can also be used extraorally. Next, coming to horizontal suture. In the horizontal mattress suture, the horizontal mattress suture is nothing but the same like vertical mattress suture, but we are giving this suture in a horizontal fashion. So how we are giving this suture? So this is useful in situations where there is need to compress the wound edges for hemostasis. So in such situations we have to use the horizontal mattress sutures. It can also be used to close wounds under moderate tension, and also to increase the wound tensile strength during the early period of the wound healing. Additionally, this horizontal mattress suture can also be used to evert the edges. So as seen in the picture, we can see that the horizontal mattress, how the suture needle is passing and the suture material is passing through the wound. So first we are using the needle holder. With the needle we will be taking, and first insertion is in the buccal flap, and then it will be again inserted into the lingual flap, and horizontally we will move the suture to the next end, and then again in the same fashion we will repeat this technique on the other side, and finally the knot will be made on the buccal side. So that is the way the suturing technique has to be done. So coming to the disadvantages. So what are the disadvantages of the horizontal mattress suture apart from the advantages? So there are disadvantages which accounts to difficult suture removal. Now how the suture removal becomes difficult? So as the healing of the tissues swells up, and once the healing is done, the suture tends to get buried under the wound, which is very difficult to remove the patient, and often we have seen that there will be pain to the patient while removing the suture. So that causes some sort of discomfort for the patient while removing the suture removal. That is why we are not preferring horizontal mattress suture for a normal extraction cases or third molar surgery or intraoral procedures. It is less likely preferred in such cases. But we do oftenly prefer such an suturing technique in lower first molar cases, where it can be easily removed without causing much discomfort for the patient. But again, as a disadvantage, there will be a discomfort of the patient while suture removal. So precise apposition of the edges may be difficult in a vertical plane, and also gaping gaping can occur in between the sutures, which is very much considered as a disadvantage of this suturing technique. So next we will talk about the sling suturing technique. Sling suturing technique is nothing but very routinely used technique, especially when you do third molar surgical technique. So once the tooth is removed and once you have put a modified Watt's incision and modified Watt's technique has been used, in such cases to suture the buccal flap to the palatal flap, it is hindered between the alveolar segment or the presence of the tooth, especially the second molar will be hindrance for the close approximation. So in such situations, what is more suitable for the patient benefit, we will advise a sling suturing technique where the needle can be taken from the buccal flap interdental papilla between the alveolar segments. That will be a gap, which is the interalveolar gap. Through the bone gap we can pass the needle to the lingual flap, and we will take this needle along with the suture material around the tooth towards the third molar region. We will take the knot in the same fashion on the opposite side, and then we will place the knot on the buccal aspect of the mandible and also buccally to the third molar. So that's how we finish the third molar surgery when we start with a modified Watt's incision. This is not advised for a Watt's incision, because Watt's incision we are not involving the 7, that is second molar is not involved. So that is away from the second molar. So that is the reason why we are not using this technique in a Watt's incision. This is always used in a modified Watt's incision. So coming to next technique, that is knotless technique. This is a very recent advance that has been mentioned in the literature, that is called as knotless technique. So the knotless device consists of a tiny barbs. So barbs are tiny projections. As you can see in this picture, you can see the small barbs which can be seen on the suture material. So this barb is a small elevation which is given in the suture that is present, entire suture material it is present, which is arising in the opposite direction on the either side of the central non-barbed segment. So the peripheral barbed segments are called the arms. So basically these are arms. So the insertion of the needle is facilitated by the needle edge, and the central knot segment is termed as the transitional point. So this like a normal needle holder, we can take it, we can insert the needle on the either side of the flap and we can just leave it. So that is why it is called knotless sutures, because we are not putting the knot. So how does the suture stay? The suture stayed with the help of the barbs, which is called as arms. So that provides the strength of the suture and provides the stability of the suture after the suturing technique. So coming to suture removal. So when do you remove the suture? So removal of suture happens, so most oftenly we ask the patient to come after 7 to 10 days once for the suture removal. So the time of suture removal depends upon again the location, whether it is we are operating on the anterior mandibular segment or maxilla, whether it is the posterior segment of the mandible, whether it's the third molar surgery, whether it's a Leafort 1 osteotomy or any other maxillofacial surgical procedure. So ideal time is 7 to 10 days procedure, and usually it can be done also up till 14 days we can do the suture removal procedure. So usually what we routinely follow in our clinic is 7 days for a normal minor oral procedure, and it can extend up to 10 to 12 days for a major maxillofacial surgical procedure. To remove the sutures, one tail of the suture should be grasped with the forceps and pulled gently towards one side, elevating the knot, and then we have to cut the opposite side of the suture will be then cut using suture cutting scissors or with the fine scissors immediately under the knot, and then the suture can be pulled out of the tissue by pulling out through the opposite side of the wound. So this has to be done very gently, and if you do gently then it will be very good for the patient also, and also we will not do any disturbance to the wound. So that is how we have to remove the suture. Thank you. This is the end of my presentation. Thank you for your patient hearing to my video and my class.